Good morning, everyone. I'm Dr. David Wild, in again this morning for Steve Stites, our Chief Medical Officer, and Dana Hawkinson and I are coming to you from the Dolph Simons Jr. Family Broadcast Studio. We did want to start this morning with a short video from the last news conference Dr. Lee Norman, Secretary of Kansas Department of Health and Environment, had. I think this is from last week. In his message here, he warned that Kansas is losing the battle against COVID-19, in his words. Listen to this summary of the White House report and what's happening in Kansas.
We are still in the red zone, which is the problem zone, obviously, for new cases at 165 per 100,000. That has us at the 10th highest in the nation. The U.S. average, compared to 165 per 100,000, is 93 per 100,000. There's shifting trends statewide and more in smaller and more rural communities, which is true. And by the way, I could add that 2 weeks ago, the White House report had Johnson, Wyandotte, and Sedgwick County accounting for 55% of the cases throughout the state of Kansas, and this week they're 35. And yet the cases are going up, which means they're happening someplace else. And they are happening in more rural areas, Dickinson County, Butler County, and there are different strategies. The hallmark still is until we get a vaccine and better antiviral medications, is going to continue to be those, what I refer to as anti-contagion efforts that are shown to work. And I've commented on a number of studies about that in the past. Masks, especially social distancing, and good hand washing and those kind of things.
So the numbers that Dr. Norman mentions in that video are at least a week old, but the patterns and the concern that he shares have continued throughout this week. We'll talk more about the numbers and the spread across the state of Kansas here shortly. We're joined today again by Dr. Heather Harris, Medical Director at our HaysMed campus. But first, Dana, numbers this morning?
Well, I'd like to say, Heather may be able to enlighten us a little bit more out west, but certainly we did have our ICU director's call today. We do have the CMO teleconference, which Dr. Stites has held. We also have the ICU group from ICU groups around the city, and in one of those, one of the conversations was even we were talking about rural, whether it's Missouri or Kansas. There have been places in Kansas where they aren't able to staff a sheriff's office, staff fire departments because of COVID-19, because of quarantine and people ill. So it's very real, and it goes back to what Dr. Burke said when she was here. We know that those infections were really high, obviously in New York, and then other metro areas such as Chicago, Houston. Overall, we knew that the South was hit very hard, and then it was moving up north, and that's what we're seeing. But now we're also seeing it move to those rural counties that thought they were not susceptible to the virus. And in fact, they can be hit harder because they have smaller workforces. And when you have people out with illness or quarantine, it really affects the workforce. Today, for our numbers here at the health system, we have 26 inpatients. We have been kind of hanging in that mid-20s range, but 7 of those are in the ICU and 6 of those are on the ventilator. We still have 33 patients that are here for in that recovery period and wouldn't be here otherwise. Out in Hays, we do have, there are 18 active inpatients, so they have high numbers as well.
Yeah, that trend pretty much continues, and we'll talk more with Dr. Harris about that here in just a minute. You mentioned, Dana, the move to more rural counties. I think we heard that from Dr. Norman in his message as well. Publicly yesterday, out on social media, the hospital in Pittsburgh, Kansas, said, we can't take care of any more people. We are closed to elective surgeries. Please only come to the hospital if you need emergency care. So that's a more rural, a non-metropolitan county at least. Absolutely. And I think Bourbon County there definitely feeling the impacts. We know we've heard that from other areas across Kansas and Missouri as well. And again, we'll talk more about that in just a second. But before we jump into those things, Jill, are there any reporters on the line who have questions today? All right, I think we'll keep moving. We'll come back to any questions we get both from the media and from the public as we move throughout the show. We'll jump out to Dr. Harris now. Heather, I think at one point in the last week or so, Hays had more active patients in the hospital than we did here in Kansas City. We heard how things are this morning, at least by the numbers. Tell us what things are like from your perspective.
Yeah, so probably for the last 3 or 4 weeks, we've had a census of somewhere in the low 20s to around like we are today in the upper teens. About half of those are from Ellis County, or maybe just a few less than half. We kind of teeter back and forth. But then the other half or other majority of them are coming from all the rural areas outside of Hays. We service, about 23 counties. So to your point earlier, those are all rural counties, all 23 of those critical access hospitals. So it just shows you, that it's hitting all of these areas. It has hit certainly several nursing homes in the rural areas to cause some of the admissions, but we're honestly probably seeing more 60 to 70-year-old admission age group here, a few younger patients in, maybe their 40s, but the majority now, ranging more maybe between 60 to 70s. I don't know if you guys see that variation as well. So again, it's just another example of how it's impacting the rural areas out here.
Yeah, Heather, we do see a decrease generally over really the past 6 months. Almost every month, it seems like the average age for those being admitted that month gets younger. I think our average age is actually in the 50s for the whole pandemic now, and if we looked at the last few months, would be in the low 50s. So I think that trend is common. You mentioned both the sort of statistic about half of the geographic representation being from Ellis County or from Hays, and about half being outside. That sounds consistent with the last time we talked with you. Is that what you feel there too? That you're really taking care of patients consistently from across a large area?
Absolutely, yeah, and that's every day for us. Before pre-COVID, even we just have a huge service area. That's what we do. That's our thing, to take care of Western Kansas. So I think it's just an example that we publicize now every day. Of what that looks like. The other comment I would make to the 50, 60, 70-year-olds that are getting hospitalized. I think people think the first week, I feel pretty good, and this isn't so bad, but they seem to actually be later hospitalizations of the illness. They don't really get hospitalized in the first week. It doesn't, on average. It appears to be that they're sick sometimes 10, 14 days and then continue to get worse and need hospitalization. I don't know if you guys see that trend too with the kind of middle-aged age group.
Yeah, absolutely. I think this is not just in that age group, but what we are thinking of right now is that COVID-19 is more of a bimodal disease, and by that means there are 2 stages. The first one is really the viral stage, where you have viral replication. You have direct damage to your cells in your body due to the viral replication, but most of the time your immune system is really able to tamp that replication down, stop the active replication. Unfortunately, what you see as what you were talking about with 10, 12, 14 days later, that is when you have that immune dysregulation. You have that large immune system process, and whether that is helping to damage some of your blood vessels, which causes the microthrombi or the blood clotting, or other parts of that, when your lungs start to fill up with that cell-free fluid and some of those dead cells that have come in to help attack and kill the virus. So there is kind of that bimodal disease aspect of that, where you're exactly right. People do have that initial illness. We heard from our patient yesterday. She felt really bad for 4 or 5 days, and we've had patients who come in with that. They don't have problems breathing. They have fevers. They have really bad aches, and then but then they get better. But then the thing to watch for is that next 10, 12, that 14 days from your original symptoms, because that's when you can have all those subsequent problems. So you're exactly right about that.
Yeah, Heather, I've one other question for you. We're seeing on average maybe 5 or 6 new admissions per day, and the same 5, 6, 7 new discharges per day. That's sort of our churn, if you will, here. How many patients are coming and going every day in Hays? Just to kind of give us a sense of the impact on the hospital there.
Right. So that's the other difference with COVID, I think, that we've talked about in the past, is that patients stay for a long time due to their oxygen needs and breathing issues. So I think there's one or two admissions maybe every day or every other day, but really the discharges, come, sometimes most people are there on average, I would say 7 days. We've had some there for weeks. We've had a couple there close to a month. So, unlike other things in medicine where people come and go pretty quickly, this illness really, once you're that sick, it takes a while to get better. And so, they're there for a while, most average. There's a few that will come for a couple of days, but a lot are there for 5, 7+ days.
Yeah, and I would like to say, we think, the impact of this is really two-pronged. So the first one is the number of cases. I don't think that it's changed. We've always said that 85% of people will not need to seek any medical attention whatsoever. That really hasn't changed. However, with simple math, as you have more cases in your community, that percentage may be the same, but those total numbers of people going to the hospital or getting critically ill are going to increase just by the simple math. The other issue is to that is even if you are not ill enough to go to the hospital, in those small communities, in any community, I mean, even in the city here, we can feel that impact because people are either out because of quarantine, because they are a contact of a patient, or they actually have illness where they're just not ill enough to go to the hospital, but they just can't work because they're ill. And so that, that is a double pronged, especially in the small community. When do you need these essential workers wherever that may be, but they can't because they're either quarantined because they're contacts or they're actual cases.
So Heather, thanks for your perspective and sort of giving us a glimpse of what things are like there. If you'll hang on, I'm sure we'll bring you back into the conversation as we talk a little more about what we're seeing across the region, not just the state. And I imagine you'll have more to share with both us and the audience. So I think we'll go ahead and move on to a couple of slides that I brought today. It's one of the benefits you get from having me fill in.
It's a good one. We like it.
I hope so. So
We like pictures.
I wanted to sort of start at the really big level and talk about what we're seeing nationwide and then work closer and closer to home. So we've heard a little bit about Kansas City. We've heard a little bit about Hays, even a little bit about Pittsburgh. But I wanted to start with this sort of look at what's happening. And here in this pretty simple graph, you see in the red line, the 7-day average number of new cases nationwide in the United States. And then the blue line is the number of hospitalizations, the 7-day average across the country. And of course, there's always a little delay. Cases start to pick up, and then a few days later, we start to see the increase in the cases. In the hospitalizations. But the I guess, important parts for me here, twofold. Number one, we are on the upswing of a third wave. Whether or not it'll be a true surge that challenges the capacity of the healthcare delivery system at the regional or national level, we have yet to see. But we're at the upstart of a third wave, where the sort of low point after the second wave didn't even reach the low point that followed the first peak. And so this sort of stair-step effect, we really do expect that this round will lead to higher number of new cases and higher number of hospitalizations as time goes on. The other important point here, I think, and it really is the title of the slide, is that for all those who keep hearing that maybe hospitalizations don't follow cases or cases aren't an important number, you can see here that as new cases per day increase, in each of the waves nationwide, all three now that we've seen, there has been the similar, almost matching increase in the number of hospitalizations. And so first, we're at the beginning of what very well is likely to be a third wave. And second, if we look at the data, at the information that we have from across really the past 7 months, as cases go up, hospitalizations go up. And so we would expect that as that red line increases, that we will see a larger impact of hospitalization across the country. The next slide moves in a little bit closer to home. And talks about regional. So across the United States, if we're talking about the Northeast, the Midwest, the South, or the West. And the values here are adjusted for population. So these population-adjusted figures show that, say in the Northeast, a peak in late April or early May of 317 daily cases per million people, the average, was really driven by New York and some of the things we saw in the metropolitan areas. And maybe in the South, the peak of 315, about the same, right, population-adjusted rate of new cases in August was the Texas or the Louisiana sort of increase we saw. And then look at the Midwest right now, 237. And while 237 cases per million per day is not the same as 315 or 317, it is by far the highest population-adjusted rate of new disease in any region of the country. So the Northeast is less than 100. The South is at 160 or so, and the West is down right around 100. So when people say the Midwest has become the hotspot and is the area of concern, this is one of the reasons. You can see that the trend, right, the slope of that line for the Midwest is definitely not flattening and remains on its upslope very, very clearly. So regionally, I think we have a lot of work to do. This sort of tells the picture of what's happening across the Midwest. And of course, then we can begin to look even closer and for some comparison. So we can look at state level, Kansas or Missouri. On the left side are the same cases that we've seen on the previous two slides. The right side, the blue charts are population-adjusted hospitalizations. And so the solid red line on the cases is our 7-day rolling average. And you can see that Kansas is higher than Texas at the moment and approaching the peak for Texas. But North Dakota, in a population-adjusted fashion, has significantly more disease spread right now, even than we do here in Kansas or in Missouri. And on the hospitalization side, the trends definitely in North Dakota are following the trend line for the hospitalizations. And actually, for Kansas, this week we've seen two of the highest hospitalization numbers ever. And they're represented by those sort of taller peaks on the right-hand side of the Kansas map. So again, moving from nationally, cases and hospitalizations increasing. Regionally, that's driven primarily by the Midwest. When we look at comparison hospitals here, or sorry, comparison states here in the Midwest, I'm used to saying comparison hospitals, we see a pattern that begins to reinforce that.
Yeah, and I would like to say, too, you know, KansasCity.com does a very good job of collating the metro area and the number of cases. And certainly for the last month, since about September 16th, it has been on a trend. And we are almost up 100 more cases per day than we were a month ago. So that's concerning as well. We were down into those, you know, the mid-200 cases per day. Now we're kind of pushing up into the mid-300s of new cases per day in the metro area.
I think, you know, in the conversation we've been having this morning about rural areas being impacted and population adjustment in that sense too, you know, Heather, maybe you can tell us how many general hospitalized patients, total hospitalized patients are at the hospital in Hays this morning, because 18 there is very different from 24 here.
Okay, ask me that question one more time, though. 18
Sure.
out of...
How many total hospitalized patients, total census in Hays today?
Let me look. I can tell you that. We've been running around 80 or 90 every day, but I usually have that by now this morning.
Yeah,
I know we've been running up. I don't have that data right now, but it's we're running around between 80 and 90 most days is our total hospital census.
Mm-hmm. And that's exactly illustrating the point I think I was making, that 18 out of 90, 20 or more % is very different from what we see here in Kansas City at the moment. So the rural impact, even with a smaller population, that rural impact can be very big. I think we have 700 and change in the hospital this morning, so 20% again would be like 140 or 150 here in Kansas City. So a really, really big impact on a hospital your size.
Absolutely, yeah, with staffing and absolutely resources, of course.
All right, I think there should be one more slide here. Oh, actually two more. I forgot I put this in last night at the last minute. So now we're moving down from the state level to county level, or age group level, age group level inside the state of Kansas. And so the top line here, if the dot is red with an up arrow. That means in the week starting on the date listed, for example, the week starting on, it looks like 10/12, the arrow was red and up. That means that the trend for the state that week is higher disease spread. The blue arrows downward, or blue dots with the downward arrows, means the trend in disease spread that week were down. And so you can see early on, right, February, March, April, the trend was up because we were starting at a very low number. We got a little bit better across the state in the month of May. June and early July, we saw a little bit of an increase, then a little bit of that drop as we moved into August. And then it's been variable, sort of this variable plateau for several weeks now. And that's at the total state level in all age groups. We've mentioned a few times that in Hays, for example, we're seeing a younger age population in the hospital. We know that that has been true here in Kansas City. We know Johnson County, for example, in the Kansas City metropolitan area, has a disproportionate number of infections, so more infections per age population in the 18 to 25 or 10 to 20 age groups. And so we wanted to look at that by state. And you can see here, really in the last week that we have a full set of data reported, really only the 18 to 24 and the 45 to 54-year-old age groups decreased. Everything else increased, including children in grade school and high school age. And so that pattern that we're showing here of really an all-around decrease the week before, moving to increases in nearly every age group in the last reporting week, is another signal. When we say we're watching things for signs or signals that give us pause and influence what we expect over the next few weeks, this is another way we look at this. Dana, as we've talked about these younger people ending up in the hospital, at least over the past several months, we've seen that our younger patients do tend to stay a little bit shorter. But I'm curious, from your perspective, there are also, I think, implications from treatments that have changed or might be available in that time, including things like convalescent plasma or remdesivir?
Yeah, I mean, during all this time, we have, finally narrowed in on, again, it's not a panacea, it's not a silver bullet, but a good therapeutic algorithm for, treating people. And it starts with the antiviral. So if you meet that criteria, if it's early enough in disease, you should get the antiviral. Again, if you meet the criteria. Certainly it's recommended for anybody who's hospitalized, but we also take into account your oxygen saturation, your age, your other comorbidities. Obviously, convalescent plasma, that was down for a little bit. We weren't able to give it. We are able to give it now. But then I really think the biggest impact that we've had besides the remdesivir really has been the anticoagulation, stopping the blood clots or helping protect against the blood clots. And then, of course, we have the dexamethasone, but you don't want to get dexamethasone. At that point, you are fairly ill. There is specific criteria to get dexamethasone because we understand that if you don't meet that criteria, you actually have a higher risk or propensity to progress towards critical illness. So all of those things have certainly helped. And moving forward, we are also looking and actively working on our protocols and systems to start to be able to give the monoclonal antibodies on an outpatient basis when that the EUA is approved by the FDA. So.
And Heather, out in Hays, I know we've had conversations. You've had conversations with Dana and with Dr. Stites, but the Hays Medical Center is able to provide those same options. It's using the same sort of treatment protocols in line with what we're doing here in Kansas City, correct?
Yeah, correct. Our hospitalists and pulmonologists are using exactly the same treatment plan that would be used anywhere else. So yeah, all the same medications and supportive care is being used here as well.
Great.
And I would say, just to, again, we really try to educate our viewers. The NIH has now published guidelines updated on October 9th. So those are available really for anybody. So it's the National Institutes of Health, the NIH guidelines for treatment and diagnosis. All those should be available on the web. And if you're bored and otherwise have nothing to do, go ahead and take a look at those. And those are really the criteria that we go off of, and it discusses all of that. So.
And that's a great point, Dana. I've had more than one conversation with family members or patients who have done their research and understand what their options are and have really great questions to help us tailor care for them based on what they've read, treatment protocols from the NIH, from the CDC, or others online. So we always encourage, regardless of the reason that you come to the hospital, we encourage you to be educated about what options there are so that you can better work with your treatment team here or in Hays or anywhere across the state to manage your care. I'm going to save the last slide for later in the show. I brought cartoons as well, so we'll maybe try to end on that. But first, Jill, any questions from the community today?
Yeah, speaking of great questions, smart questions from the community. So are you ready?
Yes, ma'am.
All right, the first one addresses herd immunity. It's from Shalene, and she wants to know if you could please discuss the Barrington report and the science behind herd immunity. She said there are a lot of people out there that think this is just going to go away, and that getting herd immunity is the way to go. She points to Sweden outlawed large gatherings, and she wants you to explain herd immunity with this, yes or no?
Yeah. I mean, the simple answer is no. Sweden, I don't know, again, quite a different country, quite different infection dynamics. I think they do have rates of death that are 10 times and 5 times higher than their neighboring countries, so I wouldn't use that as an example. And again, we have to understand, even in the United States, that local infection dynamics are just different for different communities. Typically, herd immunity means that somebody is either infected or vaccinated and get immunity. They have durable immunity that protects them. Either sterilizing protection, meaning even if you come into contact with that virus, it doesn't have any effects, or protecting you from the disease, meaning that you won't have any effects. You can have the infection, but you won't have any effects. Typically, herd immunity, really, I think until this spring when people were saying 50 to 70%, typically herd immunity means 90% or more of people have that immunity based on prior infection or based on vaccination. Those numbers that were thrown around in the spring and summer were down to 50 to 70%. I don't think that's realistic. In addition, we aren't sure that you can get durable immunity from infection. We are now seeing other cases of reinfection. There was a tragic case of a woman recently who died with her second infection. Now, granted, she was significantly immunosuppressed, but we have seen other cases where people will have no symptoms, or they may have more significant symptoms than they did the first time. So I think using herd immunity, again, not herd mentality, that's a little bit different too, but herd immunity is not the way to go in this point. There is a chance we can get some sort of herd immunity, maybe with vaccination, but we don't really understand how durable that immunity will be after vaccination. Will you need a booster in a year? Will you need different vaccines? That's really hard to say. We have to wait till the vaccines come out. But I think looking at going towards herd immunity right now without vaccination is a very dangerous prospect.
I'm not sure I've ever heard Dr. Hawkinson answer a question with a straight no. And that's as close as I think I've ever heard. And maybe to expand just a little bit on what you mean by durable. You said a couple of times the length. But what we really mean is that if you have the infection or if you're immunized with a vaccine, the length of time that the immunity from either that infection or the vaccine lasts. And so there's non-durable immunity to other coronaviruses, for example, the common cold. You get it, and you can get another very similar virus at some point that year or the next year or the year after, which might be different from, say, chickenpox, which is much more durable. So those are examples of what we mean.
Glenn has kind of a good related question. He says, antibody tests, are they worth getting, and what do they tell you?
I would say for the general public right now, antibody tests really serve no purpose. We certainly are not going to use an antibody test for diagnosis in the general sense. And again, even if you have antibodies, we don't know what those levels of antibodies are. We just don't understand exactly what they mean right now, because we know obviously you can have reinfection, especially after that 3 to 4 month period. So I don't think, other than just to check it to say, oh, I had it in the past, that would be the only reason, but that doesn't confer any other protection for you necessarily, and that certainly does not mean that you can not get in group gatherings, not wear masks, not physically distance, or do any of those other non-pharmaceutical interventions to prevent the disease.
Yeah, I agree. Bottom line, it doesn't mean, well, number one, you cannot use it for diagnosis, very clearly, not an option there. And then the results, they don't mean you're immune. They don't mean you can't get it again. They don't mean that you can't give it to the people that you're close to and love and care about. So From the individual perspective, I don't think there's a lot of value. The population health sort of nerd in me says, I would like to know how many people right now have antibodies, because that is a marker of how many people have been infected, but that's not an individual question. It's more a bigger sort of a research or a population health study question.
And that's complicated by the fact that even people who have it may have no symptoms or mild symptoms. Their detectable antibodies can wane even more quickly than, say, 4 or 5 months. So it makes it very difficult in that aspect.
Sarah wants to know, if exposed, when do the symptoms show, and how long does it take to get sick? And she wants to know if there's any difference between what we're seeing here and the illness out in western Kansas.
So I think the question around when do most people start to develop symptoms is pretty clear. It hasn't really changed, and it's the same here as it is in rural areas across Kansas or really anywhere else. And probably the earliest that people start to develop symptoms after an exposure, the earliest would be 2 or 3 days. Most start in the 4 or 5 day range, being the earliest, through maybe day 8 or 9. But the reality is, the reason there's a 14-day quarantine for this virus is it can take up to 14 days to start seeing symptoms. It's just most people start to see them in the 4 to 8 or 4 to 10 day range. And so the timing hasn't changed. It's not different in different areas. It doesn't matter. You've heard a little bit about reinfection, there being different strains or different genomic sequences, probably not truly different strains of the virus, but there's no difference in the incubation period or the time of onset to symptoms for any of those circumstances.
Yeah, absolutely. There are no evidence of any new clinically different or phenotypically different viruses. Certainly there are different isolates. We know that there have been a lot of cataloged mutations, but so far that hasn't changed from one virus to the other as far as the typical sense of a strain. All of the clinical symptoms, all of the clinical natural history of infection is still the same. So that's another important thing to note.
All right.
Okay, Debbie wants to know, if a member of the household is diagnosed with COVID, what day counts as day number 1 for the family's 14-day quarantine? Is it the first day she shows symptoms? Is it the day they tested positive?
Yeah, it would be the day that they first started showing symptoms. Because we know that you are probably most infectious 1 to 2 days prior to symptoms to about 1 to 2 days after, and then your infectiousness does decrease from there. So even if you get a test maybe 2 or 3 days after the symptoms, I would say that it's the first day that the symptoms really started. Start that quarantine from that date. And it's a little bit difficult when you are in the household as well, so there are a little bit different rules to go by, rather than just if you were at a gathering 12 days ago and you're almost up with your 14 days, because that would be an exposure where you knew you were there. It's 14 days from that last exposure. But in the household, I would say from that question specifically, I would start with when your symptoms first started.
And of course, as you work with the public health department in your area, you'll want to make sure that you're having those conversations with your appropriate public health officials. Many of those offices do, to sort of err on the side of caution, list the last day of your exposure to that family member before isolation. So if they got tested yesterday, got results today, and I've been around them today, maybe some public health offices would say you should start day 1 of your 14 days. Today is your last day of exposure. So again, that's actually cautious. That's being more cautious. I think it's very likely that the risk of transmission was higher the day before that person started having symptoms, as Dana said. So we don't want to offer any guidance that's in conflict. I think you'll get safe information from your public health office as they provide you guidance on what you should do in your individual case.
Jen has a question that maybe all the doctors, including Dr. Harris, might have an idea. She said, we talk about how Midwest is having higher numbers. What are we doing differently? Are kids playing sports, going back to school in other places, not wearing masks? What is it? What's driving it?
So Heather, we'll tee this up for you in just a second, because I think your perspective is very interesting. I can't honestly say for sure that we can pinpoint one thing. I think, I've had the opportunity to be out in Hays and in Great Bend in the last month. And I will say in Hays, I saw great evidence of routine mask wearing in the community. In Great Bend, it was different, but not none. So I think there are probably differences in the way people wear masks. I think there are differences in how people really take to heart some of those other pillars of infection prevention that we've harped on so much: physical distancing, limiting gathering sizes. We know, for example, that in July and August we were still having county fairs in some rural areas, and of course those big gatherings, maybe not at the time, but if that sort of gathering behavior continues now, where there's more infection, those things could have an impact. Dana, other thoughts?
Yeah, I certainly do think it's a cyclical process as well. Just like you said, there are people probably wearing masks. We know our guests yesterday, they had a get-together with people who they thought were in their bubble, and they got it. The cyclical process is because once you have a few people who get it, it's easy to spread. We know from contact tracing, there was an article on CNN just yesterday about a spin studio, a spin class. 61 cases attributed to that spin class, even though they were doing everything recommended by the public health authorities. They still had it. This virus just spreads with clinical efficiency, and it's very hard to decrease. So anytime you're around other people, you have that risk, and especially if they aren't in your known bubble. Are there more get-togethers? There are more things going on. There's schools. There's kids that they may not be getting and spreading in the schools, but we know that young people like to get out and about and are together in places outside of the school as well. They can easily bring that home or bring it to other places in their community as well. So it is a combination of factors for sure.
And Heather, from your perspective out in Hays?
Yeah, I think, Hays is staying pretty steady in terms of our 7-day average. It luckily hasn't grown here in recent times, although every time I seem to say that, I jinx it. But I think what's happening probably in the rural areas is exactly a combination of those things. I think, the mask wearing is probably some variation in some of those counties, as well as certainly some group gatherings are happening. And, you're seeing that across the country, of course. I guess life has to go on at some point, and how that happens safely is still the challenge between mask wearing and so forth. But certainly every time we kind of have a little bit of a burst of activity here, at least locally, it always seems to be followed by several large gatherings of some sort or the other. So, I'm a little nervous, at least right now. A lot of the group gatherings occur outside, but as the weather changes very quickly, even as this week, it'll be interesting to see as those gatherings move more to the indoors. What that could also, I'm curious to see how that's going to maybe also increase our activity, including even all the sports that are being played. The majority of them right now are outdoors, soccer, football, etc. So again, those are going to be moving indoors as well. So it'll be those are going to be some things that also we'll have to keep an eye on.
Yeah, you bring up a good point about gatherings. I think I definitely heard a story or two about gatherings, including things like funerals or weddings in some of the areas in your community, Heather. And I think that's probably just as likely to happen here, but we seem to see those things stand out a little more for whatever reason in the rural communities.
Betsy wants to know, what are the chances of catching COVID? Oh, I'm sorry, I cut off Dr. Harris. Go ahead.
No, you're good. Go ahead, Jill. Thanks.
All right. Betsy wants to know, what are the chances of catching COVID if in close quarters everyone has masks on, but there's one person who's asymptomatic?
This is like a clue.
It is a little bit. So I think, first of all, I don't think either one of us would be able to give you a percentage, a probability and odds ratio. I think we know with certainty that the more people you're around, the higher your risk of being in the same place as someone who's positive, as you mentioned, maybe even someone who's asymptomatic and positive. And there are things that we can do, mitigation steps. Mask wearing is one of them, physical distancing is another, the general principles of infection prevention that we've talked about so many times. And I suppose the best way I can answer your question is, without being able to give you a specific risk, you'll simply have to decide. For you is the value, if you will, the reason for being there in that group even with masks? Is it worth the risk of infection? And I don't know what else to really say.
Yeah, we know that it is good information that we have with the published cases from the hairdressers in Springfield, where both of them had COVID-19 at that point. They wore masks. Their clients wore masks. Obviously, as a hairdresser or stylist, you are in close proximity to your client for probably 20 to 30 minutes, possibly even longer. So that is good evidence that masking does work, masking of both parties. But we also know from this other most recent contact tracing and case reports about the spin class. Now, I'm not sure if they were wearing masks while doing the spin class, but from the public health authorities there, they said everything was being done to the T and very good, continuing to do those processes and symptoms. So if you have to do that, again, I would certainly advocate and recommend that everybody make sure they are wearing their masks. Obviously, if you start eating or drinking, masks are going to come off. Continue to maintain distance as much as you can. 6 feet is okay. Again, 8 to 10 feet is more. And again, certainly being indoors at a gathering is very dangerous. So you have to just take all those risks, take that knowledge and understand and calculate your risk and your ability to be able to do that.
Okay, we have a lot of people that are asking the same question, and let me tee it up, okay? News reports said this morning, and Vicki is weighing in on this. She goes, if this disease is so super infectious, how come people in a household don't necessarily everyone get them? And if 60% or greater don't spread within a household, which is what news reports were claiming, what's the big deal about getting together at Thanksgiving?
Yeah.
So,
a lot to unpack.
yes. I think first, maybe it's important, and I'll let Dana do this, maybe he can do it better than I can, to draw a relative comparison. So 40%, 30, 40% of those that live in a household getting infected, that rate compared to other infectious diseases, that's not low. In fact, it seems low. It seems like why not 100 or why not 80? But that really actually speaks to the infectiousness of this virus.
Yeah, absolutely. We maybe somebody or a person does spread it more. We know that maybe 10 to 20% of cases are more responsible for about 80% of cases. Are there other super spreading events, if you will? We know that gatherings certainly tend to spread it more than just household members. We know that in general it's probably 15 to 20% of a secondary attack rate within the house. We know that one of our patients, Anil, was sitting on the couch next to somebody when he was very ill and they didn't get it. So that's a very good question to ask. We don't have all the information, but all we can say is that based on these studies, this is what the numbers are. And we know that group gatherings certainly are much larger and have a higher risk. The same goes for Thanksgiving, or any family gatherings. If you are bringing otherwise vulnerable populations, meaning the elderly, somebody with underlying comorbid disease, do you want to roll that dice to say, well, it's just 30 or 40%? That's another question you have to ask. So we don't have all of the answers to that question, but we can say from the published studies that group gatherings certainly are more, and whether that's, like you said, a funeral or a wedding, which is another family gathering, or whether it's out at a bar, watching a game, or at somebody's house, as we heard from our patient yesterday, somebody who's just watching the football game with a group of friends. And I can't remember if she said most of those people had it, although were asymptomatic. So there was a large amount of people, a large percentage in that small gathering as well. And that's the best we can do. We don't know exactly why in the household itself, but certainly we know that gatherings, whether that be family gatherings or friend gatherings, does have the potential to have that super spreading or have a majority of those people infected.
And maybe the other important point to think about in your question, Vicki, is the timing matters. So Dana's mentioned it several times today. I know we've talked about it before here on the show. those that are positive and infected are actually more likely or most likely to transmit the disease. The amount of virus that they are shedding is highest the day before they start having symptoms. So if you're not around the person closely who lives in your household on that day, maybe if you're not around them for 2 or 3 days, but are later in their infection, day 7, 8, 9, they're much less likely to transmit it then. And so timing matters. And all of the variables that go into a general number of 20 or 30 or 40% are really hard to explain. But what we do know, I think, very clearly are the things that Dana just outlined. The more people you're around, the higher your risk. If you don't wear a mask, the higher your risk. If you don't physically distance, the higher your risk. It doesn't mean, in Anil's case, exactly, it doesn't mean that if you sit on the couch next to someone who's positive, you are 100% guaranteed to get it. But that doesn't mean that it's not infectious, that there are not risks, and that some in those circumstances won't get infected, and that those that get infected won't get really sick. So it's a great question. It's, I think, important to understand, but very few infectious diseases are 40 or 50 or 60% of those that have close contact will transmit.
All right, we have time for like one last question, although we have tons more. We promise we'll get to them later this week. Sherry wants to know, she says a doctor is requiring a patient to be tested for COVID-19 before that doctor will see the patient for complaints of acid reflux, sore throat, and aches and pains. He is afraid that he will get or expose himself to COVID when he goes to get the test.
A very good question. I don't think that there needs to be a large concern about that and anxiety about that. When you're getting tested, you are probably going to be alone. I know for us, we have our drive-through clinics, so you're not going to be around other people except for the person doing the test. That person is wearing a lot of PPE. Anybody doing these tests is going to be in personal protective equipment. Otherwise, if you are getting tests, say, in a lab or a clinic, I would assume that they have other infection prevention measures such as spacing, distancing, that are in those areas. Again, we have found that really healthcare facilities, and I think testing would go under that for the most part, have implemented good safety protocols and systems to protect you from that. Again, I can only speak to what we do at the health system here, and if you're getting tested here, it's a drive-through, so you are going to be okay to get those tests. I really wouldn't be too anxious about that. You can do it safely, it can be done, and you really won't have any exposure to COVID at that point.
Yeah, I would agree. I think we know from our own experience that the risk of transmission in a healthcare environment from a healthcare worker to a patient, in our experience, is zero. We watch very closely. So, of course, you'll come into contact with other people, not just healthcare workers, if you are, say, in a waiting room with others. But as Dana mentioned, everyone in the healthcare delivery space is trying very, very hard to institute the controls, the safety measures to prevent transmission in a healthcare delivery setting. So I think that concern, you can, I think, feel really good about getting a test if you need one, regardless of the circumstances. All right. Well, we will follow up with the other questions that continue to come in throughout the week, and we'll do our best on Fridays, as we usually do, to answer those we can't get to throughout the week. Dana, final thoughts today?
No, I think we are seeing an unfortunate time right now, whether, like you said, is that a surge or a wave or who knows. We know that in general cases are increasing around the nation, particularly cases are increasing in Kansas as well. It is starting to affect workforce and supply chain and essential workers. Again, not necessarily because of hospitalizations, although hospitalizations are up, but because of quarantine and just direct illness where you can't work. So it is getting dangerous. We need everybody to continue to be vigilant. Gathering, mask wearing, hand hygiene. And we've heard a couple questions today and yesterday about gathering. Don't be gathering. We know that, again, from our patient yesterday, there was a small gathering of a group of friends that they thought were safe. One of them had it, and most all of them got it. So not having the gathering, not having those gatherings, especially moving into Thanksgiving and cooler weather. Now it's supposed to be cooler, and so we know that it's going to be the weekend soon. There's going to be college football on. There's going to be NFL football on, and people will want to get together, but please be careful and continue to do the things that we've been talking about.
And Dr. Harris, final thoughts from Hays?
Yeah, just, as we move into the cold weather, the flu is going to start being around as well. So I'm really pushing the flu shot. We're starting to see a little bit of the flu. So we get to, try to fight both bugs. And, we know the flu shot works. So that's been my real push right now, as well as with the other washing of the hands and social distancing and trying to be as safe as you can.
Thanks. Excellent points. And I mentioned that I brought cartoons, so we'll start here with my final thoughts. In healthcare, when adverse events happen, we talk about this Swiss cheese model. And if you think about slices of Swiss cheese, what that's really saying is that in circumstances where bad things happen, the holes in the Swiss cheese tend to line up. And so if we take that concept and apply it to keeping your family safe, and I cannot take credit for this, by the way, I'm by no means an artist. So if you're aiming at what keeps your family safe from coronavirus, think of each of the things on the list here as a slice of Swiss cheese with the holes in slightly different spots. So physical distancing, one intervention, one barrier, but not 100% perfect. Mask wearing, another intervention, another barrier, but not 100% perfect. Hand hygiene, right? Frequent hand washing, another intervention. And then rapid testing in symptomatic patients or those who are exposed as another way to make sure that those holes don't line up. So, this is, in my mind, a really great reminder of those same pillars of infection prevention that Dr. Hawkinson, Dr. Stites, everyone really on the show have been preaching for quite some time now. Just a little bit different way to think about that. Each of these things matters. We know that if you do them, you can keep yourself safe. And that, I think, is just as important today as it really has been at any point in the last 7 months. So,
Cheese.
Cheese, yes. And everyone seems to like the cheese. All the comments on the slides are, I love the cheese. So I'll try to come up with ways to bring cheese into the picture more often. I don't know. I'll have to get creative. All right. Well, as we wrap up today, please remember to send us your mask pictures. We really do look forward to how you're using your mask with your Halloween costume this year. The information there is on the screen. Tomorrow, setting the stage, Lauren Lucht, the Executive Director of Mental and Behavioral Health here at the health system, offers insight into why some won't wear a mask. And also we'll talk about the impact of COVID-19 on the mental and behavioral health, including the added stressors, anxiety, social isolation, depression, substance abuse issues that we've heard about, both for the community and also for healthcare workers. And finally, a video to wrap up the day. Wearing a mask protects others, we know that, and local commerce, which is vital to each and every one of us across our community. So as we say goodbye, here are some thoughts from the President and CEO of the Greater Kansas City Chamber of Commerce, Joe Reardon. Dr. Stites will be back tomorrow, and we will see you then. Stay safe.
If you're pro-business, and I think we all are in Kansas City, we want to support business. We want to support our local business. And if you really want to do that, the best thing you can do is wear a mask and socially distance and be cautious.
I like to shop local and buy local and enjoy getting to have those personal relationships. So it kind of hurts your heart when you see these businesses close that you've been going to for a number of years and you've developed personal relationships with people. You just want to have them pull through.
This sits with us. It's part of this is our personal responsibility to wear a mask, to social distance, to wash your hands thoroughly and frequently. Those things matter, and they can make a difference, and they affect people's lives.
It's all about the ability to wear a mask and be respectful of the other people that are in that store so that you can maintain that distance. And by doing that, you keep everybody else healthy, the businesses stay open, and our community stays open. And I think that's just incredibly important.